Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at Home welcomes Professor Asma Khalil in London, with whom we would like to discuss COVID-19 vaccination in pregnant women. Asma, it's a pleasure for us to have you tonight. Thanks for taking the time.
Thank you for having me.
Professor Khalil is a professor of obstetrics and maternal-fetal medicine at St. George's University Hospital of the University of London. She subspecialized in maternal and fetal medicine and published over 300 papers. She has also been a member of the NICE clinical standards and expert advisor to the NICE Center for Clinical Guidelines. I would like to start off with some general questions on the pandemic and pregnancy. How high is the risk for severe COVID-19 in women who are pregnant?
The COVID can cause severe illness to pregnant women, and we know from the data that pregnant women are twice as likely to require admission to intensive care unit compared to non-pregnant adults. They're also more likely, again, twice requiring ECMO. And it's not just the mother, but also for the fetus or the unborn baby. There is robust evidence now that there is increased risk of preterm birth, twice increased risk. Also, there's increased risk of stillbirth, and there is data from the CDC. The risk of stillbirth, even adjusted to take into account other risk factors, is twice. And during the Delta period, or the period where the Delta variant was the most prevalent variant, the risk was 4 times higher. And also that's supported by data from the Scottish data that was published last week. There's also increased risk, so preterm birth, stillbirth. There's also some increased risk of preeclampsia or developing high blood pressure in pregnancy, and also increased chance of needing delivery by cesarean section.
And how far are we in understanding as to why the risk is also elevated for the baby? There has been talk about a form of placentitis or placenta dysfunction due to COVID-19. Is that something you have seen in your hospital?
I mean, certainly there are a number of reports that are published reporting findings or histopathological findings in the placenta in relation to pregnancies complicated by COVID, particularly those who had adverse outcomes like stillbirth. But even in the absence of stillbirth or even proven transplacental transmission or fetal infection, there is definitely evidence of placentitis and some histopathological placental findings, which often consistent with what you see in cases or pregnancies complicated by placental dysfunction. And most recently, there's data from NIH study where there is evidence of inflammation present in even the fetal blood or the cord blood, even in the absence of fetal infection.
So apparently there's a need for vaccination, and you just published a great review article on maternal vaccination where you clearly advocate COVID-19 vaccination in pregnant women in order to protect them from severe COVID-19. In the general population, vaccination risk is very low, with few cases of myocarditis with Moderna and Pfizer, and thrombosis and thrombocytopenia with AstraZeneca. Is there any concern that these very rare complications in the general population occur more often during pregnancy, or are there any other risks that are specific for pregnant women?
There is no evidence of safety concerns of COVID vaccination in pregnancy. It is true that pregnant women were not included in the initial COVID vaccine trials or in the mouse control trials. Hence, the reluctance of pregnant women to get the vaccine, and maybe potentially the delay of national and international bodies in recommending COVID vaccine to pregnant women. However, since over the last few months, we now have data, mainly observational data, on a very large number of pregnant women, more than 100,000 pregnant women who have received the COVID vaccine during pregnancy, and has been no safety concerns. So we know that the COVID vaccine does not increase the risk of miscarriage, does not increase the risk of stillbirths or preterm births. And therefore, I think that certainly the recommendation, rightly so, have changed over the last few months of now recommending COVID vaccine to pregnant women. In terms of the rare side effects that have been reported in relation to COVID vaccination in non-pregnant adults or in the general population, certainly there's obviously the data in pregnancy is limited, but most of the data that we have on COVID vaccine in pregnancy are related to the mRNA vaccines. The data mainly come from the States, United States, from Israel, from Canada, from UK, where the pregnant women were offered or given mainly mRNA vaccines. So the current guidance in the UK, where I practice, is to offer mRNA vaccines to pregnant women. And for the mRNA, as I said, there's been no safety concern, or to the best of my knowledge, there's been no related maternal deaths related to the COVID vaccines. I'm aware of case reports that's been published in the literature. Certainly I'm aware of one that was related to the vector vaccine, I think it was AstraZeneca, of maternal deaths, secondary to thrombotic complications, secondary to COVID vaccination in pregnancy.
And in the same review, you state that some doctors may prefer vaccination in the second or third trimester rather than in the first trimester. So if a pregnant woman comes to you and seeks your advice, who is in her first trimester and who is for some reasons not yet vaccinated, would you advocate to wait some weeks, or would you go directly to vaccination?
No, I now would recommend actually to go ahead and get the vaccine rather than waiting. It is, I can understand the rationale behind us saying in the past, perhaps maybe wait beyond the first trimester until you have your ultrasound scan, make sure the pregnancy is okay. And perhaps I'm a fetal medicine specialist, we know that the first trimester is a time where there is fetal development, and therefore, generally speaking, we try to avoid any exposure to any drug or any sort of agent that could potentially influence fetal development. Having said that, we do have data, certainly from inadvertent exposure to the COVID vaccine from the COVID vaccine trials. And again, there is no evidence that there is increased risk of miscarriage. And the data that we have so far, as I mentioned, we have data from 100,000 pregnant women, where there's no evidence of increased risk of fetal abnormalities or fetal defects. And therefore, I think we are in a position where we can confidently recommend or reassure our pregnant women that it's safe to get the COVID vaccine in the first trimester.
Here in Germany and Austria, even though there has never been a real reason to worry, but some young women are still concerned that COVID-19 vaccination may affect their fertility. We have seen in Lancet data from the Oxford COVID vaccine trial group that clearly show that vaccinated women have the same opportunity to have babies as non-vaccinated. So there's actually no safety concern from randomized trials, but still there are these concerns out there. If people come to you, how do you try to comfort these women? Or it is just something that happens in Germany and Austria, and that is not really a subject in the UK?
No, it's happening in the UK as well. I think women in the UK are similar to women in Germany. They are obviously worried about the potential risk, and I think that's where we need to be careful about mixed messages or confusion that's propagated through social media, and maybe frightening women without really any robust evidence to support that. And therefore, it's our role is to, number one, to reassure pregnant women. Number two, engage with social media and platforms to reach out to pregnant women or women even in general, to reassure them and correct the misinformation that has been there. and also to update healthcare professionals with the latest evidence, because not everyone has interest in knowing the latest evidence on COVID. And therefore, I think it's our role to ensure that we reach out to our colleagues and other healthcare professionals to ensure that they are up to date with the latest evidence.
Okay, thank you very much. You published a study, a randomized controlled trial in pregnant women. So why is it so difficult to establish a study, in a randomized controlled study for pregnant women? And what can we do to get some more studies in this field?
I think it's a really important question. And certainly we publish a number of editorials calling for pregnant women to be included in initial, whether vaccine or therapeutic trials, because the problem when they are not included, and I'll tell you why they are not usually included, that means when you have a robust evidence from a randomized control trial, you cannot apply it to pregnant women because, well, the evidence was driven from non-pregnant population, and therefore you don't know whether that can apply to pregnant women or not. And the reason is often pregnant women are not included in the initial trials, particularly vaccine trials, is that they often need to demonstrate safety in non-pregnant individuals first, and also that because of the potential medical legal implications, and obviously with pregnancy, you have two patients rather than only one patient. You've got the unborn baby or child or the fetus. It's often for trials, it's just far more straightforward and maybe less cumbersome to say we're going to exclude a pregnant woman. Hence, traditionally, vaccine trials and most therapeutic trials or therapeutic interventions, the initial ones exclude pregnant women. COVID pandemic was a perfect example to demonstrate the implication and the potential harm and inequality that result from this scenario. The fact that you have evidence of an effective intervention that could potentially save lives, but you don't know whether that's has the same effectiveness or efficacy, and very importantly, of course, the safety in pregnant women, and therefore national bodies are reluctant to recommend it to pregnant women without safety, and obviously, very importantly, is the pregnant individuals themselves reluctant to get the intervention or the vaccine because of the lack of safety. And the other thing as well is that because it's pregnancy, and I said it's a woman and a baby, that the trials often have a slightly different design. So for example, the COVID vaccine, you give the vaccine and you maybe repeat or assess sort of the effectiveness or the efficacy of the vaccine, maybe a few weeks later. While pregnant women, you need to follow up this the pregnant woman throughout the pregnancy. There's like few months until have the baby, and then you need to follow up the baby itself after the birth to ensure that the safety, or you collect robust safety data for the baby. So you can see a slightly different design and maybe a bit longer, and therefore I think I can sympathize, or I can see why pharma companies often exclude pregnant women starters.
So thank you. What are the benefits of the babies if the mother is vaccinated? And for how long do you expect an effect on the babies?
So the data on COVID vaccine in pregnancy demonstrate that, number one, the vaccine is almost as effective in pregnancy as in non-pregnant adults, so nearly 90% effectiveness against severe COVID. And also, the studies demonstrate that the antibodies cross the placenta, so the baby is born with antibodies against COVID, and also the antibodies are excreted in the breast milk, and therefore, if the mother breastfeed, that means the baby or the neonates or the newborn will also get that a degree of immunity. How long this immunity lasts for, I guess probably as long as she breastfeeds. I don't think it's fully protective. And for how long after the woman stops breastfeeding, I don't think we have robust evidence to address this question. But certainly for the time being, I don't think the newborns or neonates are seen or considered as particularly vulnerable group to COVID. And therefore, I think if I can be reassured that the newborn or the neonates getting some antibodies, whether through the cord blood or through during pregnancy or during breastfeeding, I think that would be seen as an additional benefit of getting the COVID vaccine. And certainly from talking to pregnant women, they tend to see that as a potential advantage.
So thanks. If we summarize now everything, the benefits and the risk during vaccination in pregnancy and the benefits for lactation, we have different vaccines. Which one would you recommend?
That's a very good question. And my answer is, I'll tell you what's based on evidence, and I'll tell you what is being pragmatic. So based on evidence, most of the data that we have on COVID vaccine in pregnancy, they are related to the mRNA vaccine, that's Pfizer and Moderna. And that's because most of the published data come from the United States, from Canada, from Israel, from the United Kingdom, where mRNA vaccines are the one that's given to pregnant women. And actually that's why for many countries, including the UK, for pregnant women, the current guidance is to give mRNA vaccines. Well, if I live in Africa and I don't have access to mRNA vaccine, should I be reluctant to get whatever vaccine that I have available? And the answer is no. And that's being pragmatic, because I think that the benefit, if you balance the risk versus benefit, the risk of getting COVID, getting potentially severe illness, being admitted to intensive care unit, potential mortality, risk of preterm birth, prematurity is associated with risk of disability, risk of stillbirth, versus sort of the limited evidence of this particular type of COVID vaccine in pregnancy. I think the balance would be towards getting the vaccine and getting the protection. We published a letter in the Lancet, in the main Lancet, about actually equity and the fact that actually COVID vaccination is an opportunity for achieving health equity. Is the fact that if we ensure that we can get COVID vaccine to pregnant women in low and middle income countries where there is limited access to COVID vaccine, in fact, the data demonstrate clearly that you would be able to save lives with even giving a fewer number of vaccines compared to giving the vaccine in high-income country.
I would have one final question, maybe to both Professor Khalil and to Professor Gärtner, as she's a microbiologist. Many people don't understand, if you have these antibodies in the breast milk, how will the baby be protected? How does the antibody or the immunoglobulin do get from the guts into the blood and then surely into the lungs in order to protect the baby?
I think that's a very good question. I think it's probably I think she would be more qualified than me in answering this question.
As far as I understood it, it is the IgA, and it's not working in the gut. It's working in the respiratory tract. This is how I understood it so far, but I'm not really an expert in this field.
Okay, because some way the antibody must get from the breast milk into the lungs in order to protect you there. But
I don't think that they survive the stomach.
So pregnancy remains complicated for us. It has been a great pleasure to meet you. And we are so thankful for all your work in the last 2 years, and surely even before, but the last 2 years have been clearly coined by COVID-19. And I think many, many millions of women across the world should thank you for all the work you did, for all the confidence you give to them and to us as treating physicians. So have a nice evening in London, and hopefully seeing you one day again. Thank you.
Thank you very much. Thanks for having me. It's a pleasure, and hopefully we'll meet again in a future event.